Hi, everyone. It's Alec McKenzie, elderly. For reasons I'm not quite clear on, I've been asked to moderate this wonderful session with four of my favorite residents. If I have to say that, you over the decades you identified good cohorts, and this is one of the best cohorts I've seen in some time. Did I say it exactly the way you guys typed it for me? Okay, but first, land acknowledgement quickly. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them for this land. Their culture and presence have nurtured and continue to nurture this land. We also honor all First Nations, Inuit, Métis peoples, and their valuable past, present, and future contributions to this land. Anyway, it's Sara Aljohani, Aisha Almuwaine, Nacera Hanzal, and Alanna Jane. And there's a written text here, but I just want to say I know working with them that they care deeply about equity and health information, both because of their interaction with patients, perhaps their lived experiences. So this is an area that they feel passionate about, and we're just very lucky to have you guys here to tell us all about it. So make us laugh, make us cry. I don't know who's up first. Okay.
Thank you so much, Dr. McKenzie.
Yes.
So good morning, everyone. So my name is Alanna Jane, and I, along with my colleagues Nacera, Sara, and Aisha, are really pleased to present today our Grand Rounds topic, Language Should Not Be a Barrier, Equity in Health Information for Children and Families at CHEO. Sorry, it's not clicking on the...
Click on the slide.
Oh, perfect, thank you. So we have no conflicts of interest today or disclosures, and all opinions and views expressed today reflect our own. So we also have a land acknowledgement we'd like to share with you. So we'd like to acknowledge that we are on the traditional lands today and the unceded and unsurrendered lands of the Anishinaabe Algonquin peoples. And we acknowledge this territory's significance for the people who have lived and continue to live on the land and whose practices and spiritualities are tied to the land. And we encourage you to visit nativeland.ca to find out more about whose land you are on. So I'd like to start by talking about our 4 objectives for today's presentation. So firstly, we will be describing the impact of language barriers on health outcomes, patient safety, and health equity in pediatric care. We will identify gaps in access to multilingual health information for children and families within hospital systems. We will compare approaches used by Canadian pediatric institutions to provide multilingual health information and interpretation services. And just a quick note, when we use the word interpretation, we're talking about spoken word and kind of in real time, versus when we talk about translation, we're talking about written documents. And lastly, we will be applying principles of equity-centered care to advocate for and improve access to health information for diverse pediatric populations. So now we'll go into our introduction, and we actually have a case presentation to talk to you about today that kind of sparked our interest in this topic. So this was a real case example that myself and Nacera were involved in as first-year residents here at CHEO, and again, it's what sparked our interest in the topic, and all patient identifying information has been changed. So in summary, this was an 18-month-old patient who presented to CHEO quite unwell initially. He had respiratory distress, difficulty breathing, decreased oral intake, lethargy, fatigue, and seizures, as well as metabolic abnormalities seen on their blood work. As they were quite unwell, they did require a brief PICU admission initially, and once they stabilized, they were transferred to the floor, and that's the point at which Nacera and I became involved in their care. And throughout the admission, they were supported heavily by their mother and father, who were present at bedside and spoke exclusively Arabic. So just getting into the admission timeline in a bit more detail. So the patient ultimately was diagnosed with a new onset metabolic disorder, and they were followed closely by the metabolics team as well as the dietitian. And because of this, there were several changes made to the patient's care. So they were placed on a protein-restricted diet, as well as a new special formula, and several new medications and supplements. Because of all of these changes, the family was heavily supported during the admission by in-person Arabic interpreters when they were available, as well as virtual interpreters via voice, which is the system that was used at CHEO at that time. And towards the end of the admission, kind of approaching discharge, there was still a concern that the parents perhaps still did not have the best understanding of the information being communicated. And so we did end up creating a personalized and color-coded medication table, as well as dietary recommendations to give to them to kind of have hung up on their fridge and different places in the house. But as we discovered, having it translated to Arabic ended up being a bit of a barrier to discharge, as we were told it would take 2 to 3 days to have it translated, and the patient was sort of to be imminently discharged. So ultimately, the document was translated with the help of bedside nursing staff as well as medical residents who spoke Arabic. So this case does highlight some commonly encountered barriers that we might see with translation as well as interpretation. So starting with in-person, there can be logistical challenges sometimes with scheduling and booking in-person interpreters, and this can be exacerbated with sort of conflicting schedules with other providers who might also want to see the patient that day. Looking at the virtual format, so there can be challenges sometimes with poor connection leading to dropped or missed calls, and then the lack of nonverbal communication as well with these encounters can pose difficulties with more complex and nuanced discussions with patients and families. And then lastly, as we just mentioned, there is a lack of written resources available at CHEO in Arabic, as well as other languages commonly spoken other than English and French. And we did encounter those difficulties with translating the written documents in a timely manner. Now, we were curious what happened to this patient after they were discharged. So we actually went back and did a brief sort of 12-month chart review to see sort of how they've been doing. And they continue to be followed by several subspecialty teams here at CHEO as well. So thankfully, the majority of the post-admission encounters we saw do have documented interpretation services that have been used, which was good. However, in looking at the chart, I was able to identify several recent examples of suboptimal interpretation and translation for this family. So I've copied and pasted a few direct quotes from the chart to share with you. So again, these were all quite recent. So bedside nurse speaks Arabic and has been translating for the team. Spoke with eldest son, who translated for parents. And writer indicated she would email the form with detailed instructions, but the email would be in English because there is no written Arabic translation available. So this does highlight that for this particular patient and family, there are ongoing barriers and challenges with accessing proper interpretation and translation. And with that, I will hand it off to Aisha.
Okay, so this next section I'll be talking about the background and literature review behind today's presentation. I'll walk you through what we currently know about the scope of this problem, the harms caused by language barriers, and why the current way we're dealing with those barriers, known as the culture of getting by, is simply not good enough. Okay, so the core message of this presentation is that language access is a fundamental component of clinical care. It is not an administrative task, and it is often seen as a logistical issue or something handled by a language line or a coordinator. But the evidence shows us that it is a direct determinant of health outcomes, patient safety, and health equity in pediatric care. So as you all know, Canada is home to a diverse multicultural population, and the evidence also supports that. There are 9 million Canadians that report a mother tongue other than English or French, and 4.6 million people speak a non-official language other than English or French as their only home language. And these are big numbers, and these families are navigating our healthcare system without a shared language with their healthcare provider. And as we all know, Canada's linguistic diversity is growing, and our healthcare systems need to be designed accordingly. So next I'll be talking about the dangers of language discrepancy and how families are often unable to participate in their children's care. And that's particularly important in the pediatric hospitals, where the communication triangle involves the patient, the caregiver, and the healthcare provider. And so any gaps in communication can lead to compromised care. So the first danger of language discrepancy is the increased risk of error, and language barriers can lead to misdiagnosis and delayed treatment. And as we all know, taking a good history is a very crucial step in reaching a diagnosis. And so when there is a communication gap between the healthcare provider and the caregiver, there's often compromised care, and the clinical picture is often blurred. And so that can lead to misdiagnosis, delayed diagnosis, and delayed treatment. There's also incomplete understanding of illness or treatment. Families may leave a clinical encounter without truly knowing what is wrong with their child or when to come back if their child is sick. And errors in discharge instructions and medications can have a significant impact on the child. And ideally, discharge instructions should be in the family's preferred language. And as we know, proper counseling can prevent readmission to the hospital. So a multi-center study was done in pediatric inpatient units at 7 North American hospitals, and it showed that 1 in 11 hospitalized families expressed limited comfort with English. And children with parents with limited English proficiency had 2 times higher odds of adverse events and 2 times higher odds of preventable adverse events. And that just speaks to the fact that language barriers can have detrimental safety risks. In terms of healthcare utilization, language discordance is associated with worse self-reported health. These families often describe their health as fair or poor, and they have unmet healthcare needs. And that could also be because they have difficulties navigating the healthcare system. They also have higher hospital readmissions and poorer outcomes. And evidence shows that there is a 12% increase in the odds of an emergency department revisit within 72 hours and a sustained risk of 7 days. So that tells us something important, that the initial visit failed to adequately communicate discharge instructions, and families may come back not because their child is sick, but because they weren't sure what to do at home. And most importantly, it leads to under triage in the ED and can lead to delays in diagnosing critical conditions. So what do we mean by the speak-up gap? As we know, in pediatrics, we're all about patient-centered care, and families often play an essential part of decision-making, especially with children with medical complexities. And so they can often question the decisions of healthcare providers, not because they don't trust the healthcare provider, just because it falls under the umbrella of their advocacy role. And so families with limited English proficiencies were 5 times less likely than English proficient families to question the decisions of healthcare providers. And that psychological distance can cause them to not participate in their child's care. They're also more likely to receive inadequate pain assessment and management. And so the speak-up gap is a major threat to safety, as every point of contact from admission to discharge is an opportunity for a family to intercept a medical error before it reaches the patient. So this table is from a qualitative study that shows the types of errors done by hospital professional interpreters and ad hoc interpreters. And despite the ad hoc interpreters having a fewer total number of errors, it was found that their errors were more clinically impactful. And examples of these errors included omitting questions about drug allergies or instructions about antibiotic frequency and duration. So when a professional interpreter is not available or not called, we often default to ad hoc interpreters, and that could be family members or bilingual staff, or even attempting to communicate with limited share language. And so when you use a family member as an interpreter, trust and confidentiality may be compromised, depending how close that relative is. And they might not be comfortable in translating the information depending on how sensitive the information is. So they may soften the diagnosis or omit some distressing details, or even selectively translate to protect the patient and prevent conflict. And they are also at increased risk of miscommunication and medical errors. Using a child as an interpreter is a very concerning practice, and it places the child in a very distressing and sensitive position. It causes stress and forces role reversal, where the child is actually taking care of the parents or the sibling rather than the other way around. It can also negatively affect the psychological well-being of the child and contribute to parent-child conflict. And the child is not emotionally equipped to deal with such distressing and sensitive information. And practically, it does lead to missed school time if the child is in the hospital. So the culture of getting by is driven by the fact that healthcare providers often have a time constraint, especially on a busy ward. But it's important to note that using basic language skills to get by and just relying on patients' limited grasp of English assumption is not safe, especially when it is based on nonverbal cues such as facial expression or body language, and that's not the safe way to communicate.
Thank you. So I'll be carrying on. So my name is Sara, and I'll be starting off with a digital divide. So as healthcare becomes more and more reliant on technology and digitalization, we really wanted to look at how that has impacted the language barrier and if it's widened it. And Alanna has, keep doing this, sorry. Alanna has alluded to this earlier. So with use of video remote interpreting, which is our equivalent of what was voice, although efficient and quick, but it is partly due to internet connectivity issues, which could make your interview a lot less efficient than you thought it would be. Background noise, if you're in an emergency department, it might be very, very difficult to use these interpreting services and actually hear the interpreter. And then when you want to think about a shared room environment, you also have to think about concerns of confidentiality. And when we talk about applicability, does it really apply to everyone? So when we think about patients that need sign language, that video interface is not the best method to translate some of the nuances with sign language. Okay. Now, patient portals, so our equivalent of MyChart, which are a fantastic tool to really empower autonomy for our patients and have them, have better insight on their clinical care. But if it's in a language that they don't understand, it's kind of useless. So there was, CHOP wanted to actually look into that, so Children's Hospital of Philadelphia wanted to look into that, and what they did was they allowed more customization of the patient portal to choose different languages so that it reflects what they would understand or what they would need. And they actually noticed an increase in utilization by 35% in Spanish-speaking families. Moving on to AI, which is very exciting. Getting data really quickly, real-time translation is fun, but also equity is in the details. And what I mean by that is AI lacks the cultural sensitivity and also the professional accountability that a medical interpreter or translator can provide. A few studies I wanted to share. So this one looked at use of ChatGPT in translating English to Spanish and simulated healthcare visits. And although only 3 clinically significant mistakes, there are so many omissions, additions, editorializations, which honestly can all be clinically significant if taken one way or the other. The other study I wanted to share was the use of Google Translate and ChatGPT and kind of comparing their accuracy in translating discharge instructions. And although ChatGPT fared better than Google Translate, where ChatGPT was 89% accurate, I think when we're talking about patient safety and clinical information, we want to really target 100% accuracy, or at least near that. Moving on to the language tax. So what I mean by that is how has this language barrier in healthcare impacted children in the long run? So there's a cross-sectional study that looked at early childhood developmental index scores in families that were English dominant versus families that were non-English dominant, and they noticed an 11% gap in developmental readiness. Now what they did was they did adjust for socioeconomic factors which certainly can impact development, but they found that this gap persists, which really highlights that there's a more profound sociolinguistic marginalization that happens that can have detrimental impacts on development. And then we look at a lack of medical home. Some of these patients don't have a medical compass or address. They have a really hard time navigating the medical system, especially if they don't understand or they don't have the language through which to understand it, which leads to increased adverse medical events, decreased pain management, and overall worse quality of care. And then I wanted to highlight this, a commentary that was posted on the American Academy of Pediatrics that looked at use of translation or interpretive services in inpatient care. And although the survey showed that 90% of pediatric residents were comfortable using an interpreter, only 23% used it pre-round, and then slightly better post-round at 53%, which might speak to the time constraint that Aisha spoke to. But also, you'll notice lower likelihood of caregiver being present during inpatient rounds, which makes sense, and also lower likelihood of them getting updates after rounds. Moving on to my second point, we really wanted to look at how this issue has been tackled internationally. And we wanted to focus on these 3 countries, mainly because they all share English as their prominent language, but also have a multicultural, diverse population. So starting off with the United States, now per Title IV of the 1964 Federal Civil Rights Law, no person should be subjected to discrimination based on color, race, or national origin under any program that is federally funded. And the court has deemed discrimination by national origin to include English proficiency. Now with this legal mandate, however, there still remains a huge gap. There's no standard framework by which all states follow, which leads to a huge variation in practice. With that said, I did want to highlight some institutional case studies that I thought were interesting. So at Lurie's Children's Hospital, they wanted to work on a project where they switched the narrative in who gets to decide when an interpreter is needed, the clinician versus the family. So they put in tablets in all patient rooms, walk through how to use that tablet to access an interpreter, and the onus was on the family to choose when they needed an interpreter. And not only did they notice an increase in use of interpreter from what was 6 minutes a day to 17 minutes a day, but also they noticed increased family satisfaction, obviously. And it really highlights that for these families, access was the barrier. It wasn't willingness to get an interpreter or need an interpreter. Another really cool one was run by Massachusetts General Hospital called RAD Translate, where they wanted to streamline radiology exam instructions, which were typically guided by the technologist through a medical interpreter. So what they did was they used AI to translate those or interpret them, have them standardized in different languages, and then presented to the patient instead of use of a medical interpreter. And what they noticed was decreased variation in those instructions, so everyone followed the same instructions, increased workflow, and also decreased strain on the medical interpreters. Last but not least, CHOP led a QI project in the emergency department where they really wanted to identify need of an interpreter early on. So they implemented a survey as part of their triage of whether or not they needed an interpreter, put a language tag on the emergency status board, and also put EMR alerts for need of an interpreter. And what that showed is, apart from increased identification, increased utilization of an interpreter, but they also noticed that there was an increase in documentation of need of an interpreter from almost 38% to 73%. Moving on to the United Kingdom, so NHS providers do have a legal responsibility to make services accessible to all sections of the community under the Equality Act of 2010. And despite that, there remains to be a huge gap. And under recent revisions, and quoting the previous Minister of Health, Lord Darcy, the inverse care law seems to apply. Those in greatest need tend to have the poorest access to care. With that in mind, the NHS is currently implementing a 10-year improvement plan based off of these 5 pillars, looking at leadership, access and barriers to services, equity and cultural sensitivity considerations, safety and confidentiality considerations, and digital opportunity and challenges. And 2 projects that I thought were pretty interesting that I wanted to include was one that was started in a private clinic in a very culturally diverse area. They wanted to decrease their no-show rates, or clinic no-show rates. And what they did was they put in or translated appointment reminders in different languages, and after verifying them, sent them out to the patients in their preferred language. And not only did they notice increase in appointment attendance, but also better engagement with clinical care. The second really cool project was nationally funded, and it basically looks at provision of prenatal courses to mothers who don't speak English. And what was really, really nice here is that they really focus on the cultural sensitivities and nuances in prenatal care of different cultures, which made these moms feel supported and safe. And they also provided written data or translated written data so that they can reflect on later on. And then lastly, Australia has the furthest reach in terms of interpreting and translating services that they provide to their population through TIS, which is a government-funded 24/7 interpreting service that has 160 languages and dialects. Now, seemingly easy to use, seemingly readily available, yet still under not really implemented. In a recent cross-sectional study, it showed in a pediatric KB, only 36% of respondents who identified themselves as needing an interpreter actually got an interpreter. But I did want to highlight how far this reach is. So TIS does not only provide interpretive and translative services through healthcare, but also it provides it for real estate agencies, pharmacies, trade unions, non-governmental organizations, you name it. So I think there's a huge, this highlights how they really try to help newcomers to their country navigate different parts of their lives. And with that, I will give it back to Alanna.
Great. So Sara has done a great job highlighting the international lens of this topic, but I'll be now going into doing a bit of a deeper dive into the Canadian context. And we'll be looking both at a national level as well as some more individual institutions. So to start off, this is a very recent study that was just published in March of 2026, so literally just a few months ago. And this was a national cross-sectional survey of inpatient pediatric hospital medicine leaders from over 36 hospitals in Canada, ranging from large academic tertiary sites to smaller community hospitals. And this study was conducted with the Pediatric Inpatient Research Network, or PIRN. Now, one important point that this study did highlight is that in Canada currently there are no national or provincial standards that are currently governing how language needs and preferences should be used in a pediatric hospital setting, which is a point that Sara had alluded to before with the US as well. Now, a few important statistics I wanted to highlight from this study that I thought were interesting. So less than half of these Canadian hospitals, or 41%, had any formal process in place to identify interpreter needs at either admission or inpatient registration. And then only 6% of these hospitals had a mechanism in place for being able to systematically track patient safety events, specifically for patients who use languages other than English. And this speaks to Aisha's point earlier about we know that this population is at more risk for patient safety events, but we are not able to track it, unfortunately. And the majority of these hospitals in Canada, 84%, had no formal training for staff relating to translator services. Now, also from this study, they did survey the hospital leaders asking what are the most commonly used services at your hospital. One hospital actually had no services, but the vast majority did have some type of interpretation or translation available. And the most common was telephone interpretation that was used at 84% of the sites, followed by video interpretation at 69% of the sites, and certified agency interpreters, so professional in-person interpreters, at 63% of the sites. And then looking at what is most commonly used, the survey respondents said that telephone interpreters were most often used and that the in-person interpreters were the least commonly used. Now, a really good strength of this study was that it actually did comment on the written translated materials, which was again pertinent to our patient case going back from the beginning. Now, unfortunately, only 13% of Canadian hospitals did offer any type of document translation service. However, a greater number, so close to half of hospitals, did offer some sort of standardized pre-translated materials to give to patients, such as illness-related education resources. And a particular one that was highlighted in this study was the About Kids Health website, which is a free online website that contains multilingual health information for pediatric patients. And then other translated documents available at the hospitals that did have the translation included materials relating to informed consent at 9%, discharge instructions, which were the most common, at 28%, menus for patient meals at 13%, and other unspecified documents at 9%. Now, this is taken from this study as well, and when they surveyed these 36 hospital leaders, they asked what are the biggest barriers you're seeing at your centers relating to translation and interpretation use. So I will go over the top ones that were noted. So the top one was a lack of time, so not enough time to be able to spend with families. Next, we had that patients who would benefit from interpreter services are not always being identified and documented, and this goes back to our earlier point that we made. And then the third most commonly cited barrier was interpretation services were not available quickly enough. And then I do want to touch on this fourth one as well, family declining the interpreter. So this was a point that the study kind of explained in a bit more detail, and this was thought to be rooted in a fear of stigma for these families, as well as perhaps prior experiences of discrimination or poor prior experiences, and then maybe also internalized perceptions of being a barrier, perhaps embarrassment or mistrust of the institutional services. Now, moving on to a more kind of institution level specific study. So this was taken out of Edmonton, Alberta, and this was looking at the use of interpretation services at the Stollery Children's Hospital. So this was also quite recent, published in 2025, and they surveyed 281 pediatric healthcare providers at the Stollery from 2022 to 2023 to look at, again, their use of interpretation and translation services. So some commonly cited barriers from this study, which we've seen now some commonalities, they did also cite sort of lack of availability and insufficient time. They also, a key point was not having access to the desired language, and particularly Indigenous languages, as well as other less common dialects, were noted as a significant barrier. And then lastly, the limited availability of the interpreter to accurately translate medical information as well. And then importantly, the top language identified as having limited access to interpretation at the Stollery was Cree. And this is a direct quote taken from one of the survey respondents saying that interpretation is not available in any Indigenous language, despite having a huge need for this.
That's Calgary?
Edmonton.
Edmonton,
Yeah.
okay.
And then also from this study, just looking at a few more of their results. So they did survey their staff, looking at what the staff perceive as the most effective to the least effective method of interpretation. And not surprisingly, in-person interpreters were perceived as the most effective, followed by video, telephone, and then ad hoc and lay interpreters using a website or having the pediatric patient translate were understandably kind of viewed as being the least effective. But then if we look at using the same set of respondents, what ends up actually being used in practice, we see quite the opposite. So the least commonly used method surveyed by these providers within the last 30 days was in person, with only 2.4% citing using an in-person interpreter. And unfortunately, the most common one was using an ad hoc or lay interpreter, with over 30% saying that they had used this in the last 30 days. And these results are consistent with other Canadian studies that have been done and sort of replicated similar results. So, so again, what we're perceiving as being the most effective is being used the least in practice. And with that, I will pass it on to Nacera.
Okay. All right. Okay, so Alanna really set the stage in terms of what some of the Canadian literature shows. And over the next few slides, what I'll do is go over what different institutions across the country have in terms of interpreter services as well as translation resources. Generally speaking, most pediatric centers do have some form of interpreter services. Where we start to see a gap is when it comes to the written instructions, that they're not often translated in various languages. So families get the verbal instructions, but then go home often with written instructions in either English or French. I also want to preface this by saying that this is by no means an exhaustive list of all the resources that are available in these institutions, but just a general overview. So starting off with Sick Kids, they have quite an extensive online patient education library. And I'll take a closer look in terms of some of the initiatives that are being run at Sick Kids, but they have a number of common pediatric presentations that are translated into various languages. And what's particularly unique at Sick Kids is that they've managed to integrate it into their electronic health record system, which makes it easily accessible to providers as well as families. Looking at BC Children's Hospital, they have a number of interpreter services, cultural liaison programs. They also have some templates that are translated into specific languages, but it's not integrated into their discharge workflow. And we see that that's unfortunately the case for a number of different pediatric centers. And then looking at Alberta Children's Hospital, they rely a lot on their provincial resources through Alberta Health Services. They also have a set number of templates that are translated into different languages, but much more of a reliance on interpreters as opposed to standardized templates that are integrated into their workflow. Taking another look at McMaster, so they use the voice platform, which up until recently was the platform that we were using here at CHEO, as well as different templates that are translated into the more commonly spoken languages. In Edmonton, they again use provincial resources similar to Alberta's hospital through Alberta Health Services, and then you have different organizations that provide online 24/7 support. And then finally, at the Montreal Children's Hospital, interpreters that are often available in person, and then you have virtual platforms that provide that 24/7 availability. Taking a closer look at Sick Kids, we wanted to talk about this just because it's also inspired some of the ongoing work that we have here at CHEO. So this was a resident-led advocacy initiative where the Sick Kids residents noted that despite presence of these interpreter services, there was low uptake in terms of the written translation instructions in various languages, as low as 7%. So what they focused their efforts on was creating a standardized template for common pediatric presentations that are spoken in the more common languages by families that are seen at Sick Kids. And what they did is they took this a step further and integrated that into their EPIC system so that it was readily accessible by healthcare providers and families. And what they noticed was that there was a 40% increase or improvement post-implementation, which is a notable improvement and really helps bridge that gap. And we're very grateful for the Sick Kids group because these residents have certainly helped guide us in terms of implementing an initiative similar to this one here at CHEO, which I'll be talking about in a few slides. And then just a note, we always use CPS to guide a lot of our decision making, so I wanted to acknowledge that there is a position statement that was led by Dr. Charles Huey that talks about access to appropriate interpretation being essential for pediatric care, and it covers a lot of the points that my colleagues have already discussed, but one thing I also wanted to acknowledge is things like translation services, interpretive services really should be a part of processes like hospital accreditations, because then it really shifts us towards a perspective where it becomes a standard of care. And it wouldn't be 2026 if we didn't talk about AI in this presentation. Sara has already alluded to some of the literature, but I wanted to cite some of these studies because they are Ontario and Canada-based studies. So this was a study that was based out of London, Ontario, where they compared translation of ChatGPT and Google Translate for pediatric emergency department discharge instructions. And what they ultimately found was that AI-generated translations were deemed more accurate, but no significant differences in terms of safety and understandability. And generally speaking, they found that clinicians had a preference towards AI-generated translations. And the reason we talk about AI is really because acknowledging that we are in a privileged setting at a tertiary care center where we have access to various interpretation services, but in resource-limited areas, this can certainly help bridge some of these gaps, but then also acknowledging that there are limits to AI, things like safety, accuracy, and cultural appropriateness still need to be verified, and so it can't fully replace standard of care and having those interpreters in place. And then this was a study that was authored by a few physicians based out of the Ottawa Hospital. Similar message, but ultimately what they were trying to relay is that AI-assisted translation is promising, but needs to really be thoughtfully implemented. And here, these were 4 of the key takeaway points. But our key message to you is that AI-generated translations still do need to be reviewed by either a clinician or interpreter to ensure accuracy and safety. And then for high-risk discharges, using an interpreter still remains standard of care. And then, of course, with any discussion with AI, things like privacy, data security also needs to be considered. So while it can bridge some of those gaps, like I mentioned earlier, it needs to be implemented in a cautious way. Now for some of the work that's being done at CHEO. So through the CHEO Resident Advocacy Committee, we're currently working on a project aimed at improving equitable access to after-visit summary discharge instructions within the inpatient setting. And our goal is really to translate some of the common pediatric presentations in the more commonly spoken languages at CHEO. So going over our needs assessment, so we identified there was a gap in terms of limited access to translated instructions in inpatient settings. So very often we have them existing in both English and French, but not other languages. So we contacted the data warehouse to identify what specific languages, the top 5 commonly spoken languages by families seen at CHEO, and that was identified as being Arabic, Somali, Spanish, Mandarin, and Inuktitut. And then we surveyed the pediatric medicine resident group to identify what they felt were the high-yield, high-risk discharge topics that we should really focus our efforts on, recognizing that this is an early-stage project, and the goal will be to ultimately translate everything and really try to do this within other subspecialties and departments, but as an initial step, we wanted to focus our efforts on a handful of them. Then so for this project, we were able to secure funding through the Pediatricians Alliance of Ontario, so $1,500 grant, as well as grant from our own CHEO residency advocacy committee. And throughout this project, we've been able to collaborate with services like Patient Experience Team, CHEO IIDS, to make sure this initiative is also in line with broader institutional priorities. And at the forefront of this is not just ensuring that we're accurately and safely translating these instructions, but also making sure that cultural appropriateness and patient-centered care is at the forefront of this initiative. In terms of the current status, so we're currently in discussions with the communications team in terms of how to roll out a set number of templates that have been already translated. And as with any hospital-wide initiatives, there are speed bumps along the road, and it's a learning process for all of those of us involved. But it's really trying to think of what would be the most effective and sustainable when trying to implement these new resources. Part of this is also involving accurate translation of these instructions. And then the next step would be to implement it into the Epic EBS workflow, because at the end of the day, we also want to make this easily accessible to providers to reduce burden on them, and then also accessible to families through platforms like MyChart. And then finally, big picture plan would be to ultimately translate this this type of service and resource to other departments within the hospital. So this focus is really on the inpatient setting, but acknowledging that in pediatrics, we're constantly educating families, children, and the counseling and providing them written instructions. So it would be a dream come true if we could realize this across all departments. And then a brief word on serving Indigenous families. At CHEO, we're very privileged to see a number of Indigenous families walk through our doors. And so oftentimes when we think of language barriers, we're talking about newcomer languages, but I also wanted to acknowledge that Indigenous languages also need to be taken into account. This was a service that was shared with us by Dr. Radha Jetty. It's the Inuvik Support Services, so it's a 100% Inuit-owned service that provides transcription, translation, and interpretive services. So the takeaway message for this is also trying to provide these services in a way that really empowers Indigenous-owned organizations and companies within our community. In terms of why this work matters, so moving well beyond interpreter use, it's about implementing structural change. On a more practical level, it's about empowering families such that when they go home, we're facilitating safe transition home, and they have these instructions that they're able to refer back to and reflect on and actually understand in the language of their choice. And then more broadly speaking, it's in line with national calls for health equity in pediatric care and really striving towards multilingual health communication. So families really shouldn't be disadvantaged because of the language that they speak. At the end of this presentation, we're hoping that the question you're all asking yourselves is, what role can you play? And whether you're a learner, a staff physician, allied health professional, whether you're patient-facing or not, there's absolutely a role that we can all play, and it starts off by identifying which families, which patients are at increased risk of facing these barriers and gaps, and really advocating for them. That includes speaking up within our departments and really striving to make a request for these services and translation, because if the hospital is to see that across departments there's a need for it, then they're more likely to allocate resources and funding towards translation of these instructions. And then the other piece is, throughout this discussion, we've talked about verbal like interpretation, but also written, and it's important to acknowledge that they go hand in hand. And as an institution, we should really be striving towards making that standard of care as opposed to it being an exception. These are our references. Thank you very much for listening, and we'd be happy to answer any questions.
A tour de force, guys. A tour de force. Dr. J.
Oh, I just wanted to say that was a wonderful grand rounds presentation. Thank you so much. And so many questions and comments.
We'll be talking to Dr. Jetty for the remainder of the presentation.
Just two things. One is, it's interesting that a lot of these issues come up often. wondered about translation in French. And, and I think that sometimes I found it actually even more difficult to find an interpreter for French, because I think there's an expectation in our institution that we have employees and individuals who can speak in French and English. So I guess a question about has there been any work done to identify what the barriers are to our Francophone patients that are accessing care here? How often is a professional interpreter used as opposed to someone being pulled in to interpret for us, like another employee or a medical student or whoever that may be. And then the second question I have is around using open evidence or an AI tool that is incorporated into our EPIC system for tailored interpretation in terms of documentation for our particular patients, as opposed to a standard set of discharge instructions.
Did we want to repeat the question?
Yeah, actually, whoever listened carefully can come up and repeat it.
To like the French, and then using real-time AI to generate written discharge instructions.
I can repeat the question.
Okay. And then somebody else can answer? Well played.
There you go. Oh, it says we could hear.
Hear
well? Okay, perfect. Okay.
All right.
I mean, I can speak on the. Oh, sorry. I can speak on the AI piece. I think absolutely that would, because as we've seen, AI has been integrated into our Epic workflow system when it comes to documenting clinical encounters. So how can we take that a step further to see how can we tailor discharge instructions? Because at the end of the day, yes, there are specific templates that we can provide our families, but very often we really need to tailor it based off of the needs of the patient. I think right now we're still quite early on in the AI world and the role that plays, and I don't think there's clear guidelines or a clear green light in terms of the safety of it. I think there still needs to be a lot of research done with different platforms. The literature that we had cited looked at ChatGPT. I personally didn't see anything about open evidence. But I'd be very curious to see how that can be integrated into the workflow. And then in terms of the French, Dr. Jetty, that's a really good question, because I feel like you recently had an experience where you had a hard time finding a French translator.
So I used the new Lingotech, and I had a very difficult time finding a good French interpreter through that service. So I thought that was pretty interesting. I think as this new interpreting service comes into play, it would be nice to get a better surveyed analysis of how we like that versus voice. But speaking to French and involvement of French, it is a provisional mandate, I believe, to provide bilingual services in most provinces in Canada. Now, is it optimal here at CHEO? I don't think we looked at that, but as you said, it seems to be suboptimal. I would say that there was, I think we have it in our supplementary slides, where there are provisional funds provided to help with with translation and interpreting services, but it seems like 1 to 10% of those funds are being used to utilize that. So definitely a space to work for, one, to optimize French translation and interpretation for our Francophone population, and also to kind of distribute it to all other cultures.
Anne.
That was a really thoughtful, that was fabulous presentation, and I would echo there's so many dimensions to this, like you've identified, and I wanted to say a huge thank you on behalf of taking that advocacy project and really making it go. And one of the things too that I'm thinking about with all of this that I have thought about in clinic is all the dialogue too that happens in EPIC now about patients asking questions and that being the preferred forum to do it, which I'll be honest, sometimes you walk through in English first language, like it's kind of a bit of something. So I can only imagine an appointment reminders and questions. So it really does, to Dr. Jetty's point too, like need to be integrated in EPIC, doesn't it? Because it needs to be at that level with all the exchanges that are happening in there. Yeah. But thank you.
Oh, okay, so more thanks than thank. Yes.
Amazing presentation.
People seem to like the presentation quite a lot.
So timely, and I've struggled a lot with the new translation services that recently changed. I will say it's been not a good and smooth transition. But I found particularly disheartening is in the community. When I'm at a community clinic, I've been straight up told to my face that we don't have translation services here, we're not going to offer it, so these patients should honestly just be seen at CHEO. And that like broke my heart. And I don't know why the community clinics can't have access to the same sort of services we have in the hospital and why that's such a large barrier.
Yeah, that's a really good point. And I wanted to share one of our slides. I don't know if it's still sharing the screen.
So Dr. Noyes is asking about community access for these services, not just within hospitals. And Ms. Sarah's got a killer answer she's about to share with us.
I don't know about that, but
Okay.
I don't think
People
it's not
online
sharing.
who,
Oh, it's not sharing.
to respond to some of the questions.
They have questions as well.
They want to respond to some of the comments
okay,
or questions.
okay, we'll get to that.
Okay.
I just don't, I can't share it.
You have to click on the share button.
Share, yeah.
Takes a village.
And then it's this one.
Okay, yeah. Hopefully you can see it, yeah. So this is just to Karina's point, this was a paper that we were able to find that just goes over, like has a general overview of the different provinces, because what we focus a lot of our presentation on is in the hospital setting, but like you said, Karina, what's happening in clinics and smaller centers. So this goes to show that if you're looking at the hospital generally speaking, I can't do this. Okay, I'm just going to exit out. Generally speaking, most hospitals across different provinces will have some sort of platform, but then where you start to see primary care specialists in the community, that's not consistent, unfortunately. So it just goes to reiterate your point at how sometimes we just take the easy route and say we're not going to use this, there's nothing available, but how do we try to instill some of the change and make use of the funds that we do have access to but aren't being optimized?
Yes.
I have a quick comment and a question. So the comment is, I'm not sure if you're aware, guys, that we've unfortunately lost the in-person interpretation services in the outpatient setting if the appointment is less than 45 minutes. So this is something that you might consider working on. The question is, let's assume that you got 1.5 million instead of $1,500. What are some of the things that you would change here?
Wow.
Are you making an offer?
What wouldn't we do?
So the question is, infinite money, what would they, and they wake up tomorrow morning, what are they going to do to change things?
I think really importantly is to, one, maybe continue with the CHEO advocacy project that Nacera and Alanna are involved in, which I think is most important because we want translated information that the patients can reflect on. I think making in-person interpreters more readily available would be really good because, and this I'm reflecting on the NHS use of what they mean by servicing all sections of the community. It also includes families that are not English proficient. And they really mandate that they need to allocate clinic time for these families to include interpretive services. And also, they highlight the onus is on the physician or the clinic or the healthcare institute, not the patient, to bring an interpreter. So we'd use those funds to really make those more readily available. I think if there's a better video remote interpreting service, maybe put funds there. And maybe distribute that love to the community as well. So that's one thing. And I think something that I think we really need to work on, and I'm still honestly surprised that we don't have, is including more Inuktitut translation and interpretation. So if those funds can also go to that, that would be really great.
And I think if we had a project of that scale with that amount of funding, like Sara just said, like involving community members throughout the whole process from the design phase to the implementation to the post-implementation feedback, and making sure that they have a seat at the table and that they're helping to guide how we are changing the landscape at CHEO would be really important.
You're hired. How about recipient satisfaction with all the good intentions in the world? How do you know it's working for the target populations?
I think it'd be helpful to I think it'd be helpful to like start surveys and send them after like we use this certain platform and see if they actually found the interpretation services actually useful, and if they had any like additional suggestions to make change those interpretation services.
The four of you are thriving in your third year of your residency. This looks like it might be a 10-year project, not to put too fine. I mean, the scalability and rolling it out, as Nacera, you were saying. So, what is your legacy thoughts as you know, 18 months from now, etc. Do you see a sustainability pathway here? Probably a tricky question, but any thoughts around that?
I think so.
Okay.
Well, the good news is that 10 years.
I know 10 years is being pessimistic, but I was talking with Darren McNally, who was trying to say something about urine cultures and EPIC, and it's taken him 5 years. So I was just being a bit pessimistic. But,
No, that's a fair question. This isn't something that's going to change overnight, and as I alluded to, you know, there have been bumps along the road, and things like funding can always be a barrier in terms of implementing wide-scale hospital initiatives like this one. The good news is that 3 of the 4 of us are staying for another 2 years after, so we still gives us a bit of buffer. But realistically speaking, I think if there's hospital support, I think then it holds us more accountable in terms of implementing and continuing these projects through collaborating with offices like iIdeas and patient experience.
Excellent question. Yeah, and getting friends in high places.
Yes.
Right.
There's 2 hands up.
Oh,
Okay. This is beyond my skill set.
Yes, I see Dr. Hui and Dr. Ahmed.
Okay. Who's the first one? Chuck. Yeah. Go ahead.
Yeah, hi, thanks so much. I recognize that there's not much time and appreciate that you allowed a lot of time for discussion of this very important thing. Congratulations on an amazing presentation. I think that really what you drove home is that we need to change the mindset to provide that we're actually providing substandard care, and that the solution is to have planning and to have time. Right. And that you know, time is not always there, but we really need to have that planning and time to actually provide the care that we think is important, because there's a lot of harms associated with language discordance, whether it's being spoken or written. I appreciated also that you spoke about the AI, and it really is not ready for prime time. We all like the idea. We're under stress. So this technology, you know, we're in this era now that technology is a solution for everything. There's a lot of harms associated with it. If you're getting it right, only about 80 to 90%, like imagine, okay, are we talking about doing 80 to 90% medicine where, you know, oh, well, you know, the insulin dose was wrong by, you know, a bit. It's not a big deal. It is a big deal, right? So it's nothing that we should just start right now. And then finally, caring for kids new to Canada through the CPS. We wrote to all the provinces and territories in terms of advocacy, because you showed Neil Aria's paper that, you know, once you leave the hospital setting, there's a lot of gaps everywhere, right? So BC has province-wide interpretation, but then you go to Alberta and it's patchwork, you know, and there's funding through different areas. In Quebec, it's very patchwork here and there. So we tried to do some advocacy. We wrote to all the provinces and territories, the health ministers. There was a bit of kind of like minimal kind of uptake. So we're going to still continue on that advocacy. And then caring for kids new to Canada, kidsnewtocanada.ca has guides on how to use interpretation, of which that's the next thing I'm looking at doing. In addition, I have a CIHR funded project on AI interpretation in the emergency room, but also looking at simulation, because I think we do this teaching of how to have this interaction with language discordance with people. We haven't been taught how to do that. right? So we need to do that in training. We need to do that for everybody, whether they're in training or not. So thanks so much.
Okay, and you guys are, if you're not meeting, why not? And you're going to start meeting. This is your friend in high places right here. Alex Amit, very quickly, over to you. Thanks, John.
Thank you for such a fantastic presentation and such an important topic. I ended up putting my comment written, but I'm just wondering, you guys are putting so much work into this. This is something that impacts kids across the province and across the country. So I'm wondering if there should be collaboration with other hospitals. If Sick Kids has already started to create resources, are those resources that we could use, and we could create some that Sick Kids would also use? And if it was broader, then it could also be disseminated into the community to kind of address that concern that was raised.
Absolutely, that's a great question, Dr. Ahmed, and that is actually what we're doing with Sick Kids. We are trying to avoid doubling our the work that we're doing. So if anyone who's been in the inpatient setting, if you actually search up SK when you're doing your AVS discharge instructions, you actually have access to a lot of the commonly translated templates that Sick Kids has developed. And that's just because our Epic integrates with their Epic. So recognizing that's not the case for all different hospitals, but absolutely, I think bigger picture, it would be great to do this at like a provincial level, and then eventually Canada-wide level, so that we're not becoming redundant, and instead expanding a lot of the instructions, because generally speaking, it's the same instructions. With very minor differences. So it is something that we're doing specific to CHEO with our AVS project. But I think thinking ahead, it's something that we could do on a provincial level.
Well, okay, well said. I think we're at time. Well, under my moderation, that was an amazing talk. I want to thank you. No, seriously, thanks very much. It was really one of the more impressive things I've seen. Well done.